Assalamu alaikum, everyone. My name is Dr. Sadur Rahman. Uh, I welcome you all to the 19th Shaukat Khanum Cancer Symposium. This Cancer Symposium has been going on for 2 decades, and we invite hundreds of delegates from around the world who take part in clinical talks, panel discussions, and share their expertise. Unfortunately, due to the COVID pandemic and its accompanied social restrictions, we couldn't invite all of the attendees physically, but with adversity comes opportunity, and we're going to meet every one of you on your laptop screens, on your mobile screens. So we've got a good session lined up for everyone. I'm pretty excited about it. So we're going to start off with a few talks from international and local speakers, and then we've got an interesting panel discussion lined up. So a bit of ground rules before we start. I would request everyone to keep their mics muted and not to share their screens unless I'm prompted to. I prompt you to do that. And as I invite all the speakers, uh, they'll start their presentations. So we'll start off with Dr. Leo Kevin, who joins us all the way from Ireland. It's a very early morning over there. It's about 4 a.m. over there. So Dr. Leo Kevin, brief introduction. So he's a consultant anesthetist at Galway University Hospital, a graduate from University College Dublin. He's on the examination committee of the College of Anaesthetists of Ireland. So he's an educationist, an examiner, and I've been told that he's been instrumental in starting the remote examination system. So without further ado, Dr. Leo Kevin, who's going to be talking about COVID-19 and perioperative care. So if you'll unmute your screen and you can share your slides and start the presentation.
Good morning to everybody, and thank you indeed for the invitation. It's a pleasure to talk to you all the way from the other side of the world. I have no conflicts of interest to declare. Just so you know where I am, I'm speaking to you from the tip of this arrow, which is the west coast of Ireland, and we're on the west coast of Europe. I do hope to visit you in person someday. I hear a lot about Pakistan from my 3 excellent friends and colleagues, all of whom are from Pakistan, that I work with on a daily basis. Dr. Saud Bajwa, Dr. Saeed Ali Bukhari, and Dr. Masood Awan. Wonderful doctors, each of them, and an honor to work with them. So someday I hope to set foot on your soil. Now, this is a photograph of our hospital, and simply because this is a cancer meeting, to point out that we engage in most types of cancer surgery, with the exception of neurosurgery and pediatric surgery. We're roughly a 700-bed hospital with 16 operating theatres and a second site for elective orthopedic surgery. Now, to bring you back to the COVID-19 pandemic and how it affected us and what we've done about it. As most of you will know, the European COVID story starts in northern Italy, and it's believed that it arrived with textile workers, commercial travelers coming directly from Wuhan in China back in January. And they came to Milan because it's the center of the European fashion industry at the moment. COVID virus, we think that it came to Ireland in 2 main events. First of all, directly from northern Italy during one spreading occasion, and that was northern Italians coming to attend a rugby match in our capital, an Italy versus Ireland rugby match. And the second key event, as if that wasn't enough, was indirectly through the south of England. And that was with returning Irish attendees at the Cheltenham Race Festival. And we know that many thousands of Irish people attend this every year. And certainly a number of them came back with the virus, which was spreading widely in England at the time. So it came to us, and it spread quite rapidly in the middle of March. The most memorable event of the time that I can remember, and this had an electrifying effect on the attitude to the pandemic within our hospitals, as I'll describe in a moment, was this. And this is just a photograph of it. This was shown in newspapers across the country. Many of you will have seen this also, and it's rather famous at this point. This is a scene from the town of Bergamo, Italy, on March 18th of this year. And what it shows is military trucks removing coffins of dead Italians from hospitals around the city of Bergamo. And it's removing them because the Bergamo morgues were full. There was nowhere to bury these people, and they were being removed out of the region for cremation or burial elsewhere. And this had a chilling effect on everybody, including those who were skeptical that the pandemic was really going to be a problem. So what did this mean? Well, in our country, in the middle of March 2020, all elective surgery was promptly cancelled, with devastating effects on waiting lists for all kinds of surgery. We were divided into red and green channels. In other words, patients with a suspicion of COVID or with confirmed COVID were not allowed to traverse the same hospital space as COVID-free patients, with huge knock-on effects on hospital efficiency. We dedicated an operating theatre exclusive to COVID-positive patients, although we didn't actually use it very much. We anticipated a major increase in our ICU workload, but not our anaesthesia workload. So we retrained some of our anaesthetists into the ICU and moved them into the ICU roster. We retrained also a number of theatre nurses back into the ICU, and we ran some simulation programs for intubation and extubation procedures with COVID patients, an area of major anxiety, which I'll talk about in a moment, for everybody. We converted some of our recovery rooms into temporary ICUs, although we didn't make a lot of use of those. We competed with lots of people for the purchase of equipment. There was particular anxiety over the supply of ICU ventilators, and I'll talk about that also in a moment. And we put in place an escalation plan, which included, as a final step, converting our operating theatres to ICU beds and essentially shutting down all our operating theatres, anticipating a major surge of COVID-positive, critically ill patients coming into our hospital. We were fortunate in our city that the major factory for the construction of ICU ventilators for Europe is actually local. So it was an easy job for us to source more or less as many ICU ventilators as we could get or as we could afford. And this, for example, is one of our recovery rooms, storing ICU ventilators for the expected wave of patients that was going in. There was a concern that even with this, we wouldn't have enough ventilators. And our professor of anaesthesia, Dr. John Laffey, in association with the engineering department of the local university, did some work on this device, which is called VentShare. And this is an ICU ventilator that's modified to enable it to ventilate 2 patients simultaneously in adjacent beds. I can tell you that we never actually used it. I hope we never have to, but it was there. And there's a number of different varieties of this sort of construction appeared around the world around that time. As I said, we ran endless, it seemed, simulation sessions, mainly concerned with things like intubation of COVID-positive patients, extubation of COVID-positive patients, and cardiac arrest scenarios. And this went on for some weeks while we waited for the wave of COVID-positive patients. As you can imagine, the intubation of these patients causes a huge amount of anxiety. Within about 2 weeks, we started to get our first patients into the hospital, mainly moderately sick patients and a small number of critically ill patients, which we admitted to our ICU. We were fortunate to have very close links in our department with intensive care doctors and anaesthetists in northern Italy. So they provided us with continued up-to-date guidance about how to manage these patients. This is the front page of one of our major national newspapers in Ireland. And what it says is nursing homes account for 50% of coronavirus deaths in Ireland. And what actually happened is that COVID had a devastating effect, particularly in our nursing homes, killing many very elderly people in those settings. And many of those patients would not have been considered candidates for intensive care anyway. So we actually didn't see that many. And I'll explain later a second reason for why we actually didn't get many patients into our ICU. The second event that I remember very vividly from that period is this. And I'm sensitive that some of you might actually know this gentleman because he's from Pakistan. This is the front of our national newspaper, our best newspaper, the Irish Times. And what it says is doctor dies of coronavirus after treating patients in Irish hospitals. And this is the sad death of Dr. Saeed Wakar Ali of Pakistan origin, who tragically died working in a Dublin hospital after contracting COVID-19. I never knew him, what I read is that he was extremely well liked and well regarded, and this was an absolute tragedy within the Irish medical system, and it was shown and discussed nightly on our television news. So this highlighted, first of all, the risks to staff working in Irish hospitals, which had a remarkable effect on all our behaviours. It also reinforced this observation. Now, this is an article from the Guardian newspaper in the United Kingdom, and it says United Kingdom doctor coronavirus deaths. Quite a number of UK doctors had already died during the pandemic. Highlight the crucial role of BAME medics. And BAME here, a term widely used in the United Kingdom, stands for Black, Asian, Minority, Ethnic. And for reasons unknown, a disproportionate majority of deaths among doctors in the NHS in the United Kingdom were not doctors of native English origin. They tended to be doctors who had come from other countries. Precisely why that is the case is not sure. But it was deeply worrying that we had seen the first bit of a trend of that in our own country. Very fortunately, we had no other doctor deaths throughout the rest of the pandemic. The key effect, of course, on COVID mortality risk is age. And this is a figure from Chinese data. And what it shows is what we all know now is the effect of your age on your likelihood of getting very sick and dying if you contract COVID-19. And it goes up quite remarkably with age. Now, this forced a look at our own department, at our own colleagues and their risk profile should they be working with these patients. And we did a quick back of the envelope calculation of the age profile of our department. And I would suggest you do that if you're heading into another wave. We just had one colleague who was over the age of 70, and he was obviously close to retirement anyway. So he made the decision to retire sensibly, I think, at that point. We had a small number above the age of 60, and we drew a line at about this point to identify our work colleagues who would be most at risk of becoming seriously ill should they contract the disease. And we did our best to shield them in the clinical domain. This is from a recent guideline. It was published in Anaesthesia. I'll show you where it comes from at the end of the talk, where they talk about trying to limit your staff's involvement in airway management if they fulfill certain risk factors. And it says down here the mortality curve rises significantly, as we know well, above the age of 60 years of age. And these are staff who should avoid involvement in airway management. The difficulty for anaesthetists is that airway management is the core skill of our specialty. So it's very hard to know how to manage this if you do not have the luxury of just allowing people to sit at home for an entire pandemic. We were fortunate in that sense, which is that our government forcibly took over private hospitals in the country for that period. It's essentially bought them out for a defined period of time. In our city, we have 2 entirely private hospitals, and so they were requisitioned. And what we tried to do with our older, more at-risk colleagues is try to get them working in these environments and in our standalone orthopedic hospital, which we kept as COVID-free as we could. So we engaged in not what we called non-COVID surgery in these institutions alone, and tried to isolate those patients and, of course, our staff from the major hospital, where there was a continuous stream of COVID positive patients coming in, particularly to our intensive care unit, but to a lesser degree, our operating theatres. Our anaesthesia routine changed significantly to this. So always wearing PPE in the operating theatre, which was quite something to learn, including FFP2 or 3 face masks, usually one single face mask for a day's work, provided the patients were COVID negative. Video laryngoscope is standard. I'll talk about that in a moment. We limited intubation as much as we could to only experienced intubators so that there would not be delays around that period. This, of course, had a major impact on our ability to train our beginners. So their education was significantly impaired during this period. I'll talk in a moment about the intubating box, which we later abandoned. 2-person mask ventilation, only the anaesthetist and their assistant present for induction, which meant that when the patient was brought in the room, surgeon and surgical assistants and surgical nurses all had to leave, and they had to stand outside while we put the patient to sleep, intubated the patient, and then we had a 15-minute pause before they were allowed to come back in the room, the idea being to get settling of aerosolized particles potentially containing the virus. In time, we abandoned the 15-minute pause on the advice of the infectious disease specialists who reckoned that it was probably pointless. But the same happened in reverse at the end of the operation, at the time of extubation. Everybody would leave the room. There'd be a 15-minute pause when nobody was allowed back in, and then there would be a decontamination. All sorts of ad hoc modifications to our clinical practice were seen. This is sort of one of them. So this is trying to anesthetize and airway manage a patient under a transparent plastic sheet. You can imagine how unwieldy and difficult this is. And this was not a success and didn't last very long as a practice, but we did try. It's all about trying to protect the anaesthetist and his or her assistant around the time of intubation. More successful and more enduring up to a point was this. This is the intubating box, which was rapidly produced commercially by a number of manufacturers. It's made of plexiglass, and basically it's just a big plastic box with a couple of holes in it for the anaesthetist's hand, and the idea being that you would induce your patient and intubate them while they were within this box. It was quite popular for a while. I used it myself a number of times, but opinions varied, and eventually it was abandoned. And it was abandoned because, first of all, everybody hated using it, but second of all, a couple of smallish papers came out suggesting it might do more harm than good, such as this one, where this is a rather difficult graph to describe or to explain, but basically it shows that if you have the box on the patient while you're trying to anesthetize them, you're much more likely to run into practical difficulty and create delays than if you don't. And it's reckoned that those delays and those changes in plan with air management might just create more aerosolization. And this is validated by the second paper, which is a bit easier to illustrate. So what it shows is that when the anaesthetist did not use the box, the patients were successfully intubated 100% of the time. If the box was used, that went down to 2/3, and in a third of the cases, therefore, the box had to be suddenly removed in the middle of an anesthesia induction, and that led to all sorts of problems. So we abandoned the box fairly rapidly. What we didn't abandon was the use of video laryngoscopes. So the concern that became apparent very early on to all anaesthetists was that the use of direct laryngoscopy, shown here, an intubation of the patient for anesthesia, brings the anaesthetist's face very close down to the patient's face, and this was considered to be a major risk to the anaesthetist. So video laryngoscopes became standard for us. There's several different types, of course, and the one that we chose to use primarily was the McGrath laryngoscope, which is shown here. But there are others, such as the AirTrack, which some of us prefer. The point of using a video laryngoscope is it allows the anaesthetist to stand upright at the time of intubation and therefore get their head simply further away from the patient and perhaps lessen the risk of being contaminated with COVID-contaminated aerosol. As elsewhere, a major concern within our country was the ICU bed availability. Again, this is the front of our national newspaper, and we were no different to anybody else. And this went on repeatedly as an area of concern throughout the national media. We started out, compared to most European countries, with a relatively low supply of ICU beds. In our hospital, we actually didn't have a major problem with ICU beds. We never ran out of them, and we certainly didn't run out of ventilators. And probably that is because of the nature of the countryside and habitation. We have a low population density. Much of the west of Ireland looks like it looks in this photograph, with isolated dwellings and some small villages, and not a lot of opportunity for the spreading of virus once the country was shut down. The bigger cities on the east coast suffered much worse than we did. A very real concern for us, and I was at many meetings with our hospital engineers over this, was that we would run out of oxygen. This is the Guardian newspaper again, and it says coronavirus, London hospital almost runs out of oxygen for COVID-19 patients. We were concerned that we would run into the same problem, and we almost did. We certainly got almost to the limit of our hospital supply. And the reason for that was not the management of ICU patients on ventilators, but it was the non-invasive administration of oxygen to patients during the pandemic. So if we weren't going to intubate a patient with an oxygenation deficit, there were two main options. One was to use the CPAP hood, which is shown here on the
Dr.
right.
Kevin, just prompting you for time.
Oh, yes, nearly finished. But the main concern was the use of high flow nasal oxygen. So we ended up with I'm almost finished, almost no elective surgery at all. And that was because of these reasons here. So this is our routine preparation for elective surgery. We self-isolate the patient. The patients are told to self-isolate for 14 days. They get a COVID PCR 2 days before their surgery. They get a health status questionnaire, and then if their COVID swab test is negative, they're told to come in on the day of the surgery. If I can just reassure anaesthetists out there that the evidence is now coming to suggest that the risk of aerosol generation during intubation and extubation is less than we might have anticipated. These are experiments that were done in Bristol in the United Kingdom, and they suggest that the spread of aerosol is actually fairly low during extubation. It's less than the typical volitional cough of a patient, and it's very low during intubation. So maybe we're safer than we think we were. If I can point you finally in the lines of guidelines just published in Anaesthesia, consensus guidelines for managing the airway in patients with COVID-19. It's simple and it's nicely written. So this is where we are at the moment. This is my final slide. We've been through our first wave, and we're now about here with grave concerns about what lies ahead. Thank you very much.
Thank you very much, Dr. Kevin, for that interesting talk. So we have time for a couple of questions. So I'll start off with one question of my own. What experience did you have of ventilating patients on conventional anesthesia machines rather than on ICU ventilators? And I'll let you answer that, then I'll ask you my second question.
Yeah. The answer to that is almost none. Any of our critically ill COVID patients were admitted to the ICU and were ventilated in the ICU and ICU ventilators. Incidentally, we made extensive use of prone positioning. It almost became the default situation for anyone with COVID. We never got to the point of having to convert our operating theatres into temporary ICUs for COVID patients. And we had very few incidences where we actually had to give general anaesthesia to patients with active COVID. We did a few, but usually later in their disease course, when they had recovered to a degree, and they were also considered to have low infectivity. But the actual use of the ICU, of the anesthesia machine ventilator, although we anticipated using it, we haven't had to yet.
Secondly, I would like to ask you, so there is some there's a new paper that came out that actually says that the risk of aerosolization with intubation procedures is actually less than what we initially thought. So I would like your comments on this talk, because at the moment we're still using the same precautions that we were using at the start of the pandemic.
Yep, and so are we. And there is data that suggests that, and it's reassuring, and it's made us all a little bit happier about undertaking this kind of work. I think anxiety levels are still very high, and I think we're quite slow to let down our guard about this. It does have implications for consumption of materials within the hospital. The use of PPE is very expensive, and it has these sort of precautions that we're using at the moment have major impacts on efficiency. And you probably have surgeons and patients getting very annoyed and frustrated at the slowness of everything when we take lots of precautions. I think it will take some time before everybody is sufficiently reassured that the risks are as low as we now think they are. It's interesting to see in the United Kingdom and across Europe, deaths among doctors have actually been very low among anaesthetists and intensive care doctors compared to many, for example, primary physicians and dentists and other things. And that might be because we're actually very good and careful at using PPE. And as you point out, the risks might be lower than we thought. But I think it will be a bit of time. We certainly have become a little bit less meticulous about our preparations. We're becoming a bit more efficient, and we're less worried that than we were. And that means that we're processing patients a little bit more rapidly. But I think that, for example, tight-fitting face masks and a lot of attention and a lot of fear are going to be with us for a little time to come.
Appreciate you joining us all the way from there, and I wish you the best of luck in the second wave. We're just starting to see it right here now. So. Um, So we'll move off from Ireland to another part of the world. We'll go to Saudi Arabia next. We have Dr. Riaz Ahmed, who joins us all the way from Riyadh, Saudi Arabia. Dr. Riaz is the deputy chair of the anesthesia department at the King Faisal Specialist Hospital. It's a state-of-the-art hospital. His primary interest is in neonatal pediatric cardiac anesthesia, and he's also involved in transplant surgeries as well. And Dr. Riaz is going to be talking about pediatric venous access, topic that is very close to my heart. So Dr. Riaz, over to you. While Dr. Riaz sorts out his slides, our next speaker is Dr. Khurram Ijaz. He's from Shaukat Khanum Cancer Hospital. He's a graduate from Punjab Medical College, Faisalabad. He holds dual fellowships from CPSP Pakistan and the College of Anaesthesiologists Ireland. His areas of interest include neuro and pediatric anesthesia, and he's going to be talking about anesthesia outside the operation theaters. So, Dr. Khurram Ijaz, over to you.
Thank you very much, Dr. Saad, for my nice introduction. First of all, apologies for my bad voice at the moment. And today I will be presenting on anesthesia beyond operation room and one of my article on this very topic. But before commencing, I would like to thank my department, the administration, for giving me this opportunity. And let's start from the beginning. So this very gentleman holding a piece of cloth against the patient's face was William Morton, who was the first one who introduced ethyl chloroform as a surgical anesthesia. And on 16th of October in the same year, they practically performed this experiment, and they removed a tumor from the neck, and that made the history. And over the years, in 770 years, it has become a specialty from a craft, mainly focusing on the perioperative care, and hence it enabled the tremendous advances in the surgical disciplines. So over the years, it has gone from a drop of chloroform over the rack to our present situation, where we can monitor every single organ from moment to moment, including transesophageal echocardiography or pressure volume curve or arterial blood gases or etc. etc. So everything is on our fingertip. Anesthesia services were recognized very early, way beyond, in 1950 by one of anesthetist E.M. Paper, who published an article in New England Journal of Medicine in which he wrote that it appears evident that many physicians are totally unaware of the kind of knowledge that the anesthesiologist has at his command. And unfortunately, this thing still doesn't exist in our society. But the things become more clear and evident when we confronted this COVID-19 pandemic, and we are in the front line to tackle this situation. So with so much expertise and clinical skill in hand, we are not more confined to operation theaters only. We are often delegated to some darkened and unfamiliar environment where we offer services to facilitate different procedures, sometimes complex, sometimes hidden, or sometimes minimally invasive procedures. So there is a huge list of services we are providing in radiology, interventional radiology, neuroradiology, cardiology, or you can say that almost in every specialty in a hospital, we are involved directly or indirectly. So with the rapid expansion in the outside services, different societies came up with the idea to give these services a name. And in 1999, ASA, or American Society of Anesthesiologists, published their first ever guidelines with the name of office-based anesthesia. And later on that changed to non-operating room anesthesia or NORA. And if we look at the British or Royal College of Anesthetists guidelines, it is stated as anesthesia in the non-theater environment. And in sim literature, it is written as a remote location anesthesia. So there are different names for the same services we are providing outside OR services. Okay, so in OR, we are in our comfort zone or within a controlled environment. Whenever we come out of our comfort zone, we need to face some challenges. The challenges can be in terms of concerns for safety, and safety is for both the patients and anesthesiologist as well. So there is a huge list. First of all, availability of preoperative assessment clinic, not available for all the patients all the times. We have few resources, facilities often retrofitted for anesthesia care. There is a great variations in physical setups and equipments, all decreased practitioner familiarity, that is environment, staff, and organization. Patient comorbidities unique to a particular specialty. Excuse me. So this point is very important. If we are working in a neuroradiology suite and facilitating or anesthetizing a patient for coiling, having a stroke, underlying stroke, or if we are working in a cardiology suite and during which we are anesthetizing a patient for angioplasty or something, that they're both of the suites have different concerns perioperatively. Then we have a problem of physical access to the patient. Then shared airway, we are rostered in bronchoscopy suite. Then we have to share airway. Availability of PACU and monitoring. And one study has shown that there are increased number of ASA 3 and 4 cases in outside OR. So when there are so many challenges, then there are concerns for safety, and different societies have published their own guidelines. Royal College of Anesthetists guidelines with the name of anesthesia services in the non-theater environment in 2020. Then AAGB guidelines, and likewise there are American Society of Anesthesiologists guidelines, which was last amended in 2019. And there are so many others, but all these guidelines work on one agenda, that is a patient safety. So get back to our outside cases. When we look at the growth of NORA cases or non-operating room cases, I could not find any recent data on recent years on the outside cases, but I could fetch only one article on growth of non-operating room anesthesia in United States, which is a contemporary trend analysis, and it showed only 2010 to 2014 cases up till. So in 2010, the number of NORA cases outside OR was below 30%, which went up to more than 35% in 2014. And I'm sure in recent years, this number has gone up. And if we look at our data in Shaukat Hospital, so this brown graph or brown bar represent our outside cases. In 2018, we performed 1946 cases, and in 2019, we performed 2486 cases. This number is not in coherence with the other data which I showed in last slide, because we are not doing cardiac or neuroradiology or ECT. We are only facilitating the cancer cancer cases or diagnostic or therapeutic. But when we compare it with the theater cases, from the total number of theater cases, it makes only the 25% of the total of OR cases. And if we segregate our 1 year cases into different categories, so MRI on the top, then teletherapy, CT, and radiotherapy, and PET-CT. So I would like to draw your attention on this very point. So our main services in this hospital for outside cases are non-invasive. So main bulk is non-invasive cases. And if we look at American Society of Anesthesiologists continuum of depth of sedation chart, so these cases needs only minimal to moderate sedation, but we are practicing general anesthesia here. We are anesthetizing by putting an LMA and inhalational induction, but these cases need only minimal to moderate sedation. On the other side, what are the complications of these NORA cases? This data is from National Anesthesia Clinical Outcome Registry, that is NACOR, and it divided these complications into minor adverse outcome and major adverse outcome. In minor adverse outcome, the major adverse events are postoperative nausea, vomiting, and inadequate postoperative pain control. And the third one is hemodynamic instability. These are directly or indirectly related to anesthesia we are giving. And when we look at the major adverse outcome, on the top are hemodynamic instability and respiratory problems. So both minor and major are directly or indirectly related to our anesthesia technique we are using in the NORA cases. So keeping both points, one main cohort of patient are non-invasive patients, and the other thing major and minor adverse events. So we came up with the idea of using dexmedetomidine for our outside services. So we did a study by using intranasal dexmedetomidine for our non-invasive pediatric procedure outside the operation room, in which our primary objective was to assess the successful completion of pediatric non-invasive procedures outside operation room under sedation with intranasal dexmed without any additional medication or general anesthesia. And for secondary objective, we looked at minor and major adverse events that are hemodynamic instability, PONV, bradycardia, hypotension, sedation, and third point was PACU discharge time. Why intranasal dexmed? So we all know we are using dexmed in every aspect of anesthesia, like in ICU, pain medicine, in theater. So we are using it everywhere. So we tried it for our outside services as well. So dexmed is a highly selective alpha-2 blocker with triple action, sedation, anxiolysis, and analgesia properties. And when we use it intranasally, it has low risk of respiratory depression and hemodynamic changes. And in pediatric population, it is less invasive and anxiety provoking. So it was a cross-sectional study done in this institution, Shaukat Hospital, and sampling technique was consecutive purposes sampling. So 79 patients were enrolled. Sample size was calculated by our statistician department based on previous studies. Informed consent was taken a day before, on the day of the procedure. NPO was advised as per hospital policy by the radiologist. The patients were called to holding bed 30 minutes before procedure. Baseline, on arrival, baseline vitals were recorded by the registered nurse. And we used dexmedetomidine, 4 mics per kilo, 25 minutes before the start of procedure, intranasally via 1 ml, or you can call it an insulin syringe, drop by drop. Why 4 mics per kg? The safe dose is around 1 mic to 5 mic per kilo. So we were well in between the safe dose. And level of sedation was checked by University of Michigan Station Scale. Although patients were monitored continuously throughout that period, but vital signs were recorded on hard copy after every 10 minutes. There's the Michigan scale, sedation scale 0 to 4, 4 levels. And the adequate sedation was labeled when patient achieved level 3 and above.
Dr. prompt for time.
GG. And for material and methods, a pre-designed data was used for primary and secondary, and all the patients were escorted to PACU for routine monitoring as per hospital policy. And adverse events were noted as 20% change in heart rate or blood pressure, and apnea lasting for more than 20 seconds, and oxygen drop to 90 were also recorded. So these are the adverse event, and results were successful in 95% cases without any additional need of any other drug or use of GA. And other things are the average time to achieve sedation was around 20 minutes. And side effects in none of the patient has PONV. We noted arrhythmia in 3 patients, bradycardia in 6 patients, and hypotension in 4 patients. And all the events were resolved spontaneously without giving any additional drug. And PACU discharge time was 20 minutes. Thank you very much. Questions?
Thank you very much, Dr. Khurram, for that interesting talk and this very interesting study that you have just presented. So we've got a question from one of the attendees, Dr. Aftab, and the question is, what can a radiologist or an interventional radiologist do for anesthetics to facilitate your specialty when you're attending us in radiology for procedures? Yes, Dr. Khurram.
Yes, sorry. So what I could fetch from this question, that what radiologists expect from us, or is it?
Yeah, so what can they expect and how can they facilitate us for their procedures?
If they can facilitate us in a way that if the patient is complicated and they know well that patient is having comorbidities, they can well inform us before time rather than calling the patient on the same day and telling us that we are planning this patient today. So if we get time well before the procedure, so we can, if there is anything we can optimize, so we can optimize that before doing that on that particular day. Or other thing that radiologists can do, that is on our part, that we should know what we need in a radiology suite to do for that patient, I think.
Okay. Okay, if there are no more questions, then thank you very much, Dr. Khurram, for that very interesting presentation and that very interesting study on dexmedetomidine. So we're going to go back to Dr. Riaz Ahmed. Thank you very much, Dr. Khurram.
Yeah,
So,
thank you.
so Dr. Riaz,
I was communicating with Dr. Atiq, so he guided. I belong to a BC generation before. Okay, Bismillah ar-Rahman ar-Rahim. Central venous access is a part of our daily practice in anesthesia, operating rooms, and the ICU. I will share, refresh some conventional techniques and share my experience with the techniques which are not commonly used. So there are different techniques of to access the central venous compartment: internal jugular, subclavian, brachiosphalic vein, infraclavicular axillary vein, cephalic vein, and the basilic vein. The internal jugular vein is the most commonly used technique. We can access this vein through the surface landmarks with the ultrasound. It is very inconvenient in the patients who are awake, and the good thing is malpositioning with this technique is rare. So surface landmarks, the point of skin entry is the apex of the triangle found by two heads of the sternomastoid muscle with the clavicle, or you can feel the carotid pulse and go 0.5 to 1 centimeter lateral to it. We can use the ultrasound, either the long axis view or the short axis view. The vein is compressible, artery is not. This is a short axis view. You can see the tip of the needle going in. This is the long axis view. You can follow the passage of the needle going into the vein. Subclavian vein, we can access by the infraclavicular and the supraclavicular approach. Malposition is rare in the supraclavicular approach. It is stable. It is more convenient for the patient, but there are two potential problems. One is called pinch-off syndrome, meaning that catheter is pinched between the first rib and the clavicle, the part of the catheter which is out of the vessel, and is completely blocked. And there has been case reports of indwelling catheters fracture because of constant friction between the first rib and the clavicle. So the guidelines for the prevention of intravascular catheter-related infection 2011 recommended that for optimal infection control, axillary or the subclavian veins are preferable to the internal jugular or the femoral veins. So for the infraclavicular approach, the surface landmarks you can see in the slide, the star is just lateral to the the break of the clavicle where the clavicle makes a curve. So from this skin puncture, the direction of the needle is a suprasternal notch. This is another sketch of infraclavicular approach. Supraclavicular subclavian vein catheterization, it went to obliviation for some reason, but people, they have started using it. It is relatively easy landmarks. It's a short distance from the skin to the vein. It has a more straight path to the superior vena cava, less proximity to the lungs and the subclavian artery. It has a higher success rate, and it has a fewer complications like arterial puncture, hemothorax, or the pneumothorax. Surface landmarks are, if you see this, this is the point of the skin puncture, which is formed by this is the angle formed by the lateral border of the sternomastoid with the clavicle, and the direction of the needle is towards the opposite nipple. You can see this black arrow. This is then another illustration. This is the angle, and the needle direction is this. This is a novel supraclavicular approach to the right subclavian vein based on the three-dimensional computed tomography. The traditional supraclavicular approach, the needle is advanced with 45 degrees sagittal plane and the 15 degrees the coronal plane. But this in proposed novel technique, the authors have proposed the 10 degrees sagittal plane and the 35 degrees in a coronal plane. So it is almost perpendicular. So this is another illustration of, this is the angle formed by the lateral border of the sternomastoid muscle and the clavicle, and the direction of the needle you can see from here. So supraclavicular approach is an easy and safe method of subclavian vein catheterization, even in mechanically ventilated patients. This was analyzed by the authors in 370 patients. They have demonstrated that the success rate and the complication rate is comparable with the other techniques. Supraclavicular versus infraclavicular subclavian vein catheterization was compared in this study. You see here the success rate was highest in the right supraclavicular approach and lowest in the left infraclavicular approach. In terms of complications, they have shown the arterial puncture in 3 patients in the right supraclavicular approach, and 2 patients in left supraclavicular approach, 1 patient in right infraclavicular, and 0 in left infraclavicular approach. Pneumothorax was 1 in right supraclavicular and 1 in right infraclavicular. Malpositioning was 1 that was in the pleural cavity in the right supraclavicular approach, and 1 in right infraclavicular. So you can access this subclavian with the ultrasound. This is the position of the probe for the supraclavicular approach, and you can see the subclavian vein. So in this study, they compared the ultrasound-guided supraclavicular and the infraclavicular approaches. For the infraclavicular approach, this is the position of the probe of the ultrasound, and you advance the needle just before the acoustic shadow of the clavicle. This is the position of the probe for the supraclavicular approach. This is the clavicle, this is the neck, and this is the probe. And you can see the subclavian vein here, and this is the direction of the needle. So in this study, they have demonstrated that they studied 39 patients, and the puncture time was short in supraclavicular approach. The catheter insertion time was short in infraclavicular approach. Successful guide wire insertion on the first attempt was 49% in infraclavicular and 65% in supraclavicular. The multiple attempts were lower in supraclavicular as compared with the infraclavicular group, and complication was 0 in both groups. Guide wire misplacement was higher in infraclavicular group and none in supraclavicular group. So brachiosphalic vein is formed by the junction of the internal jugular with the subclavian. And here's the brachiosphalic. Before it was innominate vein, now it has been named. Both brachiosphalic veins join to form the superior vena cava. It is located just behind the medial fourth of the clavicle. So the surface landmarks are, if you pass your finger from the manubrium sterni over the clavicle, just short distance from the medial end, you will find a small notch over the clavicle, which is more prominent in the pediatric group. So the skin insertion point is just above this notch, and it is posterior and inferior with 80 degrees in a coronal plane and a 0 degree in the sagittal plane. So you can use the ultrasound, inferior vena cava, this is the superior vena cava, and this is the brachiosphalic vein. So axillary vein access was it was introduced in 1987. This study was done by the cadaveric dissection. They just showed the landmarks. So the landmarks in this approach are the coracoid process, where the pectoralis minor muscle is attached, and point of skin entry is A, which is patient's 3 fingers in a vertical plane, and the direction of the needle is towards the junction of the medial 1/4 with the lateral 3/4 of the clavicle. This is the anatomy. Axillary vein is divided by the pectoralis minor muscle into 3 parts, part medial, part posterior, and part lateral to this muscle. So the first clinical studies were done in 1990. They did 102 patients, and failed cannulation was in 4 patients, catheter malposition was in 6, arterial puncture was in 5, transient paresthesia was in 2, pneumothorax in 1, and extravascular placement in 0. So this is the landmark technique. This is the coracoid process. Patient's 3 finger below. It's a patient 3 finger, not operator 3 finger. In a vertical plane, this is the point of skin puncture, and direction is the point A, which is the junction of the medial 1/4 with the lateral 3/4 of the clavicle. So you can use the ultrasound. This is the axillary vein, and this is the axillary artery. So ultrasound guided infraclavicular axillary vein, this article was a retrospective study done after studying 2,500 patients. This is the axillary vein, this is the axillary artery in a short axis view, and this is in a long axis view. So this is the catheter going, you can see the long axis view, catheter going into the axillary vein, and you see the cephalic vein joining the axillary vein in a short axis view. I will show you some x-rays. This is a lung transplant patient. You see, you can even introduce the Swan-Ganz catheter. So Swan-Ganz catheter is going through the axillary vein into the right pulmonary artery. You can use this technique in a pediatric patients. In this patient, this was introduced through the left axillary vein, but this ended up in the left superior vena cava. So we had to change it at the end because superior vena left SVC drains the coronary sinus. This is another 3 kilo patients. You see in the beautiful X-ray going through the subclavian vein, and even smaller children. This was a child 2.7 kilograms. Cephalic vein travels along the medial lateral border of the biceps. It joins the axillary vein in the deltopectoral groove. Surface landmarks are, the red star is a point of your skin puncture. this is between the coracoid process and the clavicle, and the direction of the needle is parallel to the clavicle, and you will hit the cephalic vein here. And you see from here, it is way away from the thoracic inlet, which is formed by the superior surface of the first rib. So you can use the ultrasound. This is the position of the ultrasound, and you can see the long axis. This is the cephalic vein. It is joining the axillary vein in the short axis. I will share you with some x-rays. So this is the coracoid process. This is the clavicle. The catheter is going through the cephalic vein, entering the axillary vein, then the subclavian vein, and going into the SVC. The smallest child I could put was 10 kilos. Below that weight, I was unable to secure the cephalic vein. See here, it is going in the cephalic vein and entering the axillary and subclavian and going into the SVC. Here is another patient. You see the catheter going to the cephalic vein, and the Swan-Ganz sheath is going into the axillary vein. Axillary and cephalic vein, it's easy to compress. They are extrathoracic. There is not a major structure near the cephalic vein, not a big artery, except the thoracoacromial trunk, which is a branch of the axillary artery. It's very safe. Even if the patient has a coagulation problems, you can compress it easily between the thoracic edge and your finger. Malpositions are not uncommon. So this is the catheter I introduced to the cephalic vein. It entered the axillary vein and went back into the basilic vein. So I was not happy with the reading on the monitor. So I put another cephalic vein on the other side, and post-op X-ray showed that it was misplaced. So basilic vein is the safest vein. So usually you can access in the mid-arm region. It travels around the medial border of the biceps muscle. You can use the ultrasound, and here is the ultrasound image. Basilic vein is here, and this is the basilic artery. Thank you very much for your attention. I think I was within my time.
You certainly were, Dr. Riaz. Thank you for that very interesting talk. I think we all learned some new techniques regarding the cephalic and the basilic vein. So I have a question for you regarding the durations for which you can keep these catheters, especially if you're putting long-term catheters like Hickman lines and ports. Would you still prefer these small veins as compared to the larger veins like the internal jugular or the subclavian vein?
Yes, there are two reasons I will prefer those. Internal jugular vein carries a high risk of infection, and long dwelling catheters for chemotherapy or parenteral nutrition. The subclavian vein, there is a risk of fracture where the friction between the first rib and the second rib. Our cardiologists, they usually ask me to put the guide wires in the axillary vein and the cephalic vein so they can put their two leads for the pacemaker, because there have been fracture case reports for pacemaker leads as well.
And what is the incidence of thrombosis when you're using these smaller veins for large size catheters?
Yeah, the axillary vein is a quite big vein, and the incidence of thrombosis is comparable with the internal jugular and the subclavian.
Mm-hmm. Okay. So if any of the audience members have any questions for Dr. Riaz, they are welcome to unmute their mic and ask him the question directly. Okay, thank you very much, Dr. Riaz. I think still early, still early morning in Riyadh. We appreciate you taking the time and joining us.
No, it is at 8 o'clock. Our theater starts at 7 o'clock, so I took the day off.
Okay. So have a nice afternoon.
Thank you so much. Thank you.
Okay, so that concludes our three talks for this session, and now we're going to move on to a very interesting and very complex panel discussion. So, if I can ask my panel to unmute their screens and share their videos. So, I'm going to uh, briefly introduce our panel for today. So we've got two local experts, and then we've got two national experts who are joining us as well. So to start off, we've got Dr. Syed Raza Mehdi. He's a consultant anesthetist at Shaukat Khanum Memorial Cancer Hospital. He's got a wide experience of working in Pakistan and in Ireland. His areas of interest include regional anesthesia and non-opioid based anesthesia. So joining him again from from Shaukat Khanum Hospital is Dr. Almas Iqbal. She's an FRCA with experience in England. Her areas of interest include regional anesthesia and pain management. She also happens to be one of the moderators supervisor at one time. So next from Shifa International Hospital, we've got Dr. Mohammed Ashraf, who's a consultant anesthetist. He's also the head of Department of Anesthesia, Pain and Critical Care, and he's also holds the title of Associate Professor at the affiliated university. And last but not the least, we've got Professor Arshad Taki, who's a consultant at Call Associates and Rashid Latif Hospital. He's an educationist, he's an examiner, he's a researcher, and he's also a regulator in terms of being a member of the Pakistan Medical Commission. So I thank all the panelists for joining us. I would like the audiences to please share your comments, ask questions in the chat box that I'll put through the panelists. And the topic of our discussion, so I'll just share the screen, is globalization and its impact on healthcare. Do we need specialized anesthesia care? So globalization is actually a very vast term in terms of how we define it. We use it very commonly in our day-to-day language, but if we define it, it's a process of interaction and integration among the people, companies, and governments of different nations. So globalization means different things for different people if you're depending on which side of the world you live in. So if someone is living in US, it would mean differently, and if you're working on in the Eastern Hemisphere like we are, so it has different meanings. So essentially it has been used in the commercial and the economic industry as with regards to trade and commerce. However, it has impact on healthcare, on cultural, political, social norms. So we're going to start off this discussion. I'd start off with Dr. Mohammed Ashraf. And sir, I would like your comments on what, in your view, you think globalization means for you.
Bismillahirrahmanirrahim. Thank you very much for inviting me. Are you hearing me?
Yes, we can hear you very clearly.
As you mentioned in the introduction, when we talk about the globalization, and it covers a lot of aspects, including the economy, including the traveling, and especially when we are talking about the healthcare, it includes the transfer and exchange of expertise, exchange of knowledge, and taking the benefit of experience of from the developed countries to the underdeveloped, and even the more important experience from the underdeveloped or less developed countries and managing their resources. But even this globalization also includes the transfer of the COVID-19 recently we are talking about, and simultaneously the management of that. If we are going to talk about the globalization in healthcare, and particularly I would like to come my own field, anesthesia. I would like to say one thing, that in simple word, when we talk, it is the exchange of knowledge and an exchange of experience, exchange of expertise. But simultaneously, I would like to say one thing, which my rest of the colleagues uh, will either they support it or they can differ, have their opinions. When you talk about the opportunities for the people to move from the underdeveloped countries or less developed countries to the especially for the Western or developed countries, where we talk about the resources movements, I would like to say the manpower movements from these countries to those developed countries. In my point of view, as far as if we talk about the exchange of knowledge, the exchange of expertise, even the medical curriculum, all these things. But the best impact for our part of the life, they were that our people who moved from Pakistan to the rest of the world, our manpower is being drained, and there are less chances that those people are coming from other back to the country. It means we are still in the part that we are producing the manpower, but this globalization has an impact. In my view, it is not a positive impact. I am not denying, but simultaneously I'm talking, I can hardly see few people who moved from here and they are coming back. For the specialty of anesthesia, when we talk, here we know what is the level of anesthesia. Only the big cities, they are clustered, but our 60-70% population, we know that. I don't want to go into detail, but I would like to say that we should focus in this point, that definitely we are getting the benefit of exchange of knowledge, expertise, technique, but simultaneously we have certain problems in our field. We should focus on that. We should try to focus that this globalization should affect our subject. As far as I've seen the many articles, this is not the problem with us. This is even the problem with the developed countries, that those rural areas are facing the same problems. And my point of view, with I'll definitely I request my colleagues to particularly highlight this area. Uh, Thank you very much. And if you
So very, very interesting comments on the start of discussion. Dr. Reza Mehdi, you have experience of working in both in government setups. You got experience of working in private setups in Pakistan, in international setups, and do you think do you think we are truly living in a globalized world? I mean, currently we're talking to people in Ireland and in Saudi Arabia, but do you think it is kind of being conveyed to our people who are actually working in rural areas? Sorry, I think we've got a problem with Dr. Raza's. Is it sorted? Oh. Sorry, so I'll move on to Professor Arshad Taki. Sir, if you would take the same question, you have got these same amount of diversity of experience in terms as Dr. Raza has. So if you wouldn't mind answering this question, the disparity between rural, urban, and then international setups.
Yeah. Thank you very much. Can you hear me?
Yes, yes, we can hear you.
Right. Thank you. And first of all, I begin by thanking you and a very, very generous introduction. One thing I really am not is I really don't qualify to be called a researcher. I don't have that many publications. I just kind of had a few, but my primary area of interest, of course, was besides clinical manager work, teaching and training, and now a bit of management thing that was kind of imposed on me. But coming back to the question, yes, yes, of course, we find huge disparity. If I may kind of introduce myself, I actually come from a rural background. I am from a farming family. I'm the first doctor in the family. So, but I also must concede that I was one of those. We were one of those privileged who got the best schooling, who went to the best schools, and but still, if you are coming from the rural areas, then you are really connected with your people, and you know how they live, how they think, how they speak, because you have got a closer contact with them. Uh, I must say one thing, that the disconnect between rural and urban in terms of, there are two ways of looking at it. One is disconnect in terms of quality of life. Yes, there is a disconnect in the quality of life, but that disconnect you see is seen more at the upper spectrum of the socio-economic order, where you find that people who are richer and living in cities have got a lot more opportunities and lot more resources at their disposal as compared to people who are relatively richer and living in the semi-urban or urban areas, rural areas, sorry. So, but when it comes to the lower spectrum of our socio-economic order, I must say that the quality of life here of people, of city dwellers, is a lot worse than the quality of life that a person living in the urban, rural areas still has access to, in terms of breathing space, in terms of access, cleaner air, even in terms of the food that they eat. So that, of course, the next thing is access to opportunity. What I find now, even in rural areas, is that a child, if parents want to send their child to the school, at least to the level of high school, they have got reasonable opportunities even in the rural and semi-urban areas. Then the graph that actually then separates when it comes to higher education, where of course moving on to international, of course, when we move out of Pakistan, and anyone who has ever traveled, and of course, most of you have traveled a lot, would realize that there you see a huge difference. Difference in the way we live, the way we do things. Even in terms of access to knowledge, there is a huge disparity. Access to healthcare, once again, there is a huge disparity. So in that terms, the globalization actually, to me, is more of a globalization in our minds due to our greater access to information. So now a person who is living in Pakistan can feel connected to whatever is happening in the rest of the world. But in terms of physical barriers, there are tons of barriers in our people from lower income countries traveling to higher income countries. So in terms of physical contact and physical access, we still are not really not a globalized country. Try asking that from someone who has illegally migrated from here to Europe, and ask them about their story, and they will tell you what globalization, the limits to globalizations are. So I hope that answers the question.
Okay, so that's a very, very interesting point. So Dr. Azamedi, I hope your
Can you
sound is
hear me
sorted
now?
out. Yes, I can hear you now.
Now, coming directly to the point, the term globalization have different meaning to the different nations or different countries or different. Can you hear me?
Yes, we can hear you.
Okay,
Very clearly.
so the point is the globalization has a different meaning for different people, different culture, different countries. You can talk about from the point of view of the first word to the second word, which I consider Pakistan is a second word, or you can talk about from the urban point of view to the rural point of view. The global changes which are happening for last, I would put on 30 or 40, where this term globalization came up, and it was very rapid initially. I'm talking about 90s and 80s and 90s were very rapid globalization concept and economic terms. But then people started doing selective globalization. If you purely from the economic point of view, what was happening in 90s, and then we come to this century, let's say put it in this way, the sorry, the march of the McDonald, it has stopped. I mean, that's from the cultural point of view. I'm talking about eating habit or cultural point of view. And if you have noticed from the economic point of view, the Walmart, the American chain company who started in India, has to wrap up his setup from the India, going back to the America. And same thing happening from the trade restriction on the Chinese goods. So this is some sort of selective thing. The Dr. Ashraf was mentioning about the concept which was happening to Pakistan or still happening is the concept of the brain drain. We have individuals, but they are going to the other side of the world to get a better life. And if I go from the perspective of a Irish setup where I worked, once they realize that they are losing their brain, they are getting brain drain from their country to the Americans or to the Australians or to the UK people, they have to have a policy. This policy does not mean that you have to pay highly to the professionals, but they also know that the people who are migrating are not only because of the salaries, but also because of the social setup, because of the education opportunities for their children, so on. We can go on from this point of view. So we need to have a cultural and social setup as well. Pakistan as a country, as a society, and as an anesthesia community, we are at the back foot. I would put it in simple way, back foot. We are not participating in the globalization concept. Coming back again, moving forward to the COVID era, which we are going through at the present, and I expect that we have to go through this period for next at least year or two. That's my assessment. The point is, we are getting less and less physical travel, less and less attending the actual conferences and moving to their social networking setup of the other countries, or we can say from the anesthesia point of view, the developed anesthesia community. We have to rely on our webinars, which we should initiate locally with international collaboration. Yes, we are doing at the present in this Shaukat Khanum Symposium. We should also develop this sort of setup to the urban and the rural setup as well. I should not say the rural setup, let's say put it in the smaller cities, the correct word. And the other correction, which I mean, someone of the speaker mentioned about the 70% population living in the rural area, 30% in the urban area. Internationally speaking, again, this is the first year that this trend has actually reversed now. And there are more people in the world living in the cities than in the rural area. This happened for the first time in the world history. So hopefully this trend is, if it's not come to Pakistan yet, it is going to come over here. So we are going more urban centers in here. So at least if we can try to develop the small anesthesia centers, I mean, with collaboration with we can sort it with the webinars, we can talk about the exchange, or we can talk about the WhatsApp groups, or whichever way you have, we have to rely on this setup. The other things, I mean, globalization, from the globalization view, we have to live with this. Whatever definition you do, we have to move forward where we are now. We are not utilizing our internet setup. We are not utilizing even our time setup as well. So hopefully, as like Shaukat Khanum or Pakistan Society of Anesthesia should start doing this sort of concept, as we don't have any PSA meeting this year, the year just gone by. So I hope that webinar culture should go there as well. Dr. Taki might put a comment on this webinar concept for the PSA, but anyway, my thought is we should move in this direction anyway. Thanks. Over to you.
So I would like to add Dr. Almas to the conversation. It seems like globalization is getting a beating. We're talking about brain drain and movement of people from smaller cities to larger areas. but it has got its benefits. We're all, we've all trained in what we call first world countries. We're sharing guidelines. I can just Google American Heart Association guidelines. I can look at the Royal College of Anesthetists recommendations. So I would like to get your views on on what we're actually getting in terms of globalization.
I think that the globalization, while it has its bad points about it in terms of the restriction of the trades that they have, or in terms of the manpower movement, I do agree with Dr. Taki in that way that we probably had free movement of manpower in past compared to what we have now. There is far more restrictions which are being imposed. The borders are not as porous or as free as they used to be. And similarly, it's like when it comes down to the globalization in terms of the trade, the supply lines, if you look at those supply lines, especially the COVID has revealed the vulnerabilities of every supply line around. You would have people moving the production overseas for the pursuit of lowering their economic cost. But they have realized that it's quite intricately tied up with our security as well. So if you have your food production, your medical supply line production overseas, talking from the West point of view, or for Pakistan, which imports most of its stuff or used to, we are making ourselves more vulnerable. So that when one country who's producing your drug says that we are going to fulfill our own local demand before exporting it to you, you suddenly become more vulnerable in terms of your own population security. Similar, the whole thing about globalization is obviously there are economic benefits which certain countries have reaped. So not all have benefited from globalization. Uh, you may be on the globe, but it's not that you are part of globalization. Well, I do have slightly a pessimistic view about globalization, and there are a lot of good things about it. Yes, you can say that the communication, the flow of information is quite free. You can have webinars, you can have, but it's a very, very centralized flow of information as well. When we are talking about the guidelines that we download from the overseas, looking at the societies, the research that they're basing it on is on a certain population. Those guidelines are for a certain population, which may or may not hold true for our own population. So when we do take the information or the misinformation that comes through the lowering of information and communication, you can see that how misinterpreted and out of context we can be implementing it on our own population. So COVID is a very good example of why the information and the guidelines has to be decentralized. Because when you look at the COVID, it's like going by the global trend. It was all lockdowns and strict lockdowns and shutting down, and a lot of panic response on a country levels. But for our own country, far more localized thinking in terms of what our country needs and what our population trends are. That insight has probably benefited the country as a whole. So globalization after the COVID is probably going to take a bit of a hit, in the sense that probably nationalistic and patriotic sentiments are more on the rise now. So people are who were thinking about globalization for economic pursuit only, they are now thinking about bringing back the production lines, thinking about a more decentralized approach to their local problems. And one thing I would really like to add over here is that globalization is a very, very centralized approach to probably some very local problems. And it does hurt when when there is a kind of like economic incentive being created to move the population, and the brain drain that Dr. Mohammed Ashraf mentioned as well is a glaring example of how the global elite tends to reap the benefits of globalization to a greater extent compared to those who are on the losing side. So even in Pakistan, globalization probably benefits more the bigger cities compared to the periphery and the rural areas, and the economic reaps that you're benefiting, uh, that has a direct consequence on the poverty of our population. And one should mind that the poverty is directly related to health. So people who are more poor, who have more social determinants of health not in their favor, would would be probably far more on the losing side, and we are a very vulnerable population from that point of view. So sorry, Dr. Saad, but I can't see much of a benefit in globalization. I'm more of a nationalist and patriotic approach in from
Interesting,
that
interesting.
point of
So,
view.
so coming back to Dr. Ashraf, I mean, no one is stopping us from, developing our resources, or kind of, no one is actually forcing. It's not a slave trade going on that, people are being loaded into ships and being shipped to Western hemispheres. So, so my question for you is, is it just a one-way street? Are we, is a big old or Uncle Sam, reaping all the benefit while we suffer?
Thank you very much. Uh, the first part which I would like to mention, I mentioned it. Nobody can deny the benefit of globalization. And I mentioned that it includes the economy, it includes the knowledge, technology, expertise, disease transmission, and even the treatment in medicine. And I also talked about the benefits of this globalization. I just try to focus on the subject of anesthesia, and that's why we can even talk about a lot of on this globalization. But taking the constraints of the time, I try to focus on our subject. uh, we are privileged that Dr. Arshad Taki Saab is sitting with us. uh, my I want to draw the attention of my other panelists to be more focused on anesthesia care. And definitely, among all these were involved, while their national policy for safe surgery, obstetric, anesthesia plan, I want to say one thing. Nobody can deny the benefit of the globalization. But very interestingly, Dr. Almas rightly pointed out the direction is the flow is unidirectional. We should think about the flow should be bi or multi-directional. For example, if we are taking the benefit of globalization, we all are sitting here, even we are talking about taking the benefit of the technology, that now we are sitting in the different cities and we are exchanging our views. When we talk about this point of view, we should focus on that. One of my colleagues has mentioned the webinars, the PSA meetings, and the training, the workshops. All these things are the better tools which we want to focus on it. While in the initial, you started from the discussion, and the whole direction of the globalization moved in other direction. I would like to say, and I will request my rest of the colleagues to comment on that. Nobody can deny that we can exchange the knowledge, we can exchange the expertise, we can make arrangement of the workshop, but simultaneously, we should take the benefit of the Western world or the developed world. They are definitely, they are focused in their main cities. You have gone through multiple articles, and they try to develop one thing, that the man we are I would like to say that we are intelligent people, we are having a good medical education. The thing is that unfortunately that benefit is not being transferred to our population. If we talk about the anesthesia, we know that the people are being trained not only in Pakistan, the people are trained in Western countries, in America. And how many people are thinking that we are living in this part of world, how we are going to develop our system? Definitely, I agree that nobody can have we can stop anybody to move, but at this level, we should think about that, how we can develop our own infrastructure, how we can retain the people, and what we can do for our people who are here, how we can improve their knowledge, how we can improve their techniques, or we can adopt the various models so we can serve our population. My main point was that, and I would like to request my rest of the people, colleagues, and when mind one thing, it is very much clear. When we talk about the term of the globalization, the person who comes with the idea, whether in the form of the ventilators, whether in the form of the medicines, whether in the form of the technologies, the person or the country or the company or the multinationals who are bringing this idea, they have got their own motives. And we should know simultaneously that we should think, at least at our level, that definitely we should have our own interest, and how we are going to watch our interest. Thank you.
So we've got a lot of questions and comments from the audience as well. So I'll just put it to Professor Ashtaki. So you have been mentioned a couple of times by Dr. Raza and Dr. Ashraf as well. So how can we use this to our advantage? We are all anesthetists over here. How can we improve anesthesia services? How can we, put anesthesia subspecialty on the map? We're always talking about how anesthesia is not, doesn't get its due share in terms of when it stands with other subspecialties. So how can we, improve that in the context of globalization?
So first of all, if you give me a second, just two little clarifications. I mean, clarifications, I like to read history. So just kind of my take on this globalization. First, globalization was a term coined by the industry, by the multinational companies, just to make the flow of trade actually, essentially it was all about the flow of trade. But let me remind you, there has always been free trade. And I'm sure all of you have heard the word Silk Route. So that Silk Route, that Silk Road was all about free trade between Europe all the way to China and India and Persia. And there were other trade routes as well. Yemen trade route to was one of the most important, because that's where our religion was born, on the crossroads of that trade route in Mecca. So globalization has always been there. It was only with the development of nation states that these barriers were raised, and those tariffs were raised, and that's when and then came in globalization. So this is nothing new. The world has always seen globalization. The world has always been thriving on free trade, and the world has always done better when there has been free trade. But now, and second, free trade in every kind of trade, in every kind of world, I like it or not, you like it or not, it is always the smartest and the rich and the powerful who benefit the most. And to the poor, it always is the concept of trickle down. And be that in knowledge as well. So coming back to anesthesia. So I've got a slightly different take on this. The way when I talk to my anesthesia colleague and they talk about the position of anesthesia in the vis-a-vis other specialties and within our healthcare system and how our role is not recognized. And if you forgive me for using a term, but I just have a feeling that we are asking for this as like beggars. No, sir, you don't ask for things, because if you ask for things, nobody is going to give them to you. You just take the things that are your due share. There are two dimensions to it. One is that we are providing service. Now everybody knows that 70% of the patients in the hospital benefit from anesthesia care, according to at least one study at some point or another. We're talking about anesthesia outside OR, perioperative care, pain, critical care, everything. However, what we are missing is that now nobody is going to try and be your advocate while you are providing all that care. What you are not doing is, once you're done with that care, taking that little bit of time off to train ourselves in matters of organization, in matters of advocacy. If you go back and look at the CanMEDS model, which is CanMEDS model that the Canadians have developed for a good doctor, one of the important attributes of a good doctor is advocacy. And advocacy means advocacy for the cause. So if we are doing what we're doing and we have not been able to convince the society that we are delivering all that, then the problem lies with us, not with anybody else. So we have to take a little time away from our routines and dedicate that to convincing the world that we are providing that. We have to come up with data. We have to come up, and it's a constant struggle. One little thing purely in context of globalization, and Dr. Ashraf said brain drain. Brain drain is a reality, sir. It will happen. Whenever people find opportunities, they would want to move. And we have had a long discussion on that. We are having a continuous long discussion on that, even within the PMC, that how do we deal with that? We are looking at what we think we should be doing is making sure that we are training enough people and we are recruiting enough people in the specialty so that even with the brain drain, and I don't call it brain drain because not with this free flow of information, people who are leaving for abroad, some of them are coming back, but even those who are not coming back are there for us to benefit from. So we can see through the webinars, as Dr. Saad has suggested, as Dr. Raza has suggested, through the webinars, now we have access to our colleagues whom we would not meet for years. So we've got greater access to their experiences, their knowledge. What we need to do is recruit more people into the specialty, train them and train them well. And there we've got a problem. Our problem is at this moment that we are living in a dichotomy. We have what we realize is that there are now two parallel training programs running in our hospitals. The universities program and the College of Physicians and Surgeons program. Previously, 80% of our graduates were coming from College of Physicians. That is going to change with central induction system. So the government is supplying half of the trainees, and it is becoming popular with due respect because their pathway of entry into the specialty is easier. So now you as trainers have got one problem. That problem is that you got 8 trainees who are training for FCPS, 8 training who would be training for MS, and their criteria for induction is not uniform. So you may not have people with that similar baseline knowledge. But at the end, once again, there are 2 different exit exams. So we as a licensor have got a problem there. How do we ensure that issuing a license to these people coming from 2 different pathways is going to be valid globally? Because what we want is that our people actually, on the basis of the license we issue them, can be acceptable all over the world. So that's where you people who are the trainers come in. You have to make sure that these people, when they are, because see, that exam for 2, 3, 4 days of exams is just a sample. The most important thing is that the completion of training certificate that you award as the supervisors, that's what actually ascertains the competence of an individual. So in that context, taking that plea by Dr. Ashraf forward, I think end of the day, onus is on us, on the specialty. Nobody is going to give it to us. We need to go on and take it and take responsibility. I hope that answers the question as well.
Mhm. Yes, it answers the question and it opens a very interesting point as well, which I'll put to Dr. Razan Hedi. So, dealing with two training systems, dealing with people you have been trained in Pakistan and in Ireland as well, and then we've got trainees who are working in Pakistan. So how do we kind of implement or train the doctors who are working under us, having knowledge of a training system that is different from us? How do we kind of translate that to our trainees
Okay.
working
Okay.
on this side of the world?
Now we are moving from the globalization to the national level now. Okay, from the national level point of view, we have got a problem, and this is not new problem. We are getting this problem for last 72 or 73 years by now. The problem is we, from the very beginning up till now, we are not focusing on quality. We are focusing on quantity. When we are, let's say, initially we did not have a training, then we start getting specialist training, then we started with the we don't mind my wording, because I'm talking about the historical point of view. When I'm talking about the DAs, then we are talking about the MCPS, and this took decades from move from one point to the other point, and then we're talking about FCPS, and now we are talking about the two system. One is for MS, and one is for the FCPS. Now, my point is we should move away from producing the manpower with the mediocre capacity. This is the basic concept we are still sticking with. We should move away from the producing mediocres. First thing. The second thing that Dr. Taki pointed about from the MS point of true parallel system of the training, higher specialist training from the MD, MS, and to the FCPS. I agree with this. This is happening, and this is I think the governments were trying to promote this setup for last decades now. They were different governments, not single government, different government were trying to promote one aspect over the other, which was wrong. But anyway, this is happening, what is practically happening. My point is there's a solution, I mean, possible, not my solution, but this is happening in the Western world as well, like UK and Ireland setup as well. They only consider the FCPS, or we can put it MD as well, as an entry exam, not the exit exam. We are still treating FCPS and the MDs as the exit exam. So they change their concept, and they are talking about you should have done your this exam before actually during this specialist training, and your training is different after certain period, which may be 4 or 5, whatever period you decide. Then you are given the CCST, and you're given the training certificate. Training certificate and the FCPS or the MD, they are two different aspects. So we should realize that we have to go to this model as well. This is one aspect. The other aspect is we, even as a trainer as well, we should give more time to our trainees to observe and to teach them. Now, my point is, again, this is a problem with the system as well. I myself as well, we were trained and we were educated to pass the exam. We have to change our mindset as a trainer. We are not training our trainees to pass the exam. We are training them to become good anesthetists and specialized in their own field. So this is the concept change. I don't know how to implement on the gross level, but we have to change this mindset from the just to pass the exam and then to actually taking care of the patient. Okay, it's up to the other people what they think and how they comment on this aspect. It's over to you.
So we're running out of time here. So I think I would like final comments. I think from all the panelists, starting from Dr. Almas. How do we improve patient care, anesthesia services in the context of globalization? How do we use it to our advantage since it's not going away?
I think that globalization is like in terms of collaboration, in terms of the technology transfer, with a bit of a pinch of salt there too. But one can look and explore the potential of those things. But coming back to the comment that in terms of the two-tier systems of like, the MS and the CPSP programs being run, considering the dilemma that majority of our rural area does not have any health structure or not to the extent that we can be proud of, one has to realize that it's not only anesthesia in context of globalization, but also in context of health itself. So if there is no primary health care, if there is a fragmentation of health, each episode of health interaction is a standalone and there is no continuity of care, then there is not going to be any decrease in the chronic disease burden. And therefore, the anesthesia, when we are talking about our own specialty, the raw product or the patients that we would be encountering would be far more difficult to deal with compared to in a well-functioning, more primary care-based system where there is some continuity of care so that the anesthetist can have or at least deliver quality care. Thank you.
Okay, so we're almost out of time. Professor Shataki, if you will take us towards the end, I would like to read one comment that we are not the only country who's dealing with the mediocre level trained healthcare. So, Shataki Saab, if you'll take us to the end of this panel discussion.
Thank you very much. I think this actually should be the beginning of a dialogue that Dr. Saad, that you have a very interesting dialogue that we have created, and I think this dialogue needs to be ongoing. Some very interesting points raised by Professor Ashraf. Of course, Dr. Almas had very intelligent comments, and Raza and I have go back so long that we understand each other and we understand each other's concerns. And I agree. Actually, if theoretically speaking, the College of Physician Surgeons says that our curriculum is competency-based curriculum, so which means that objective is to produce a competent anesthetist. But however, since end of the day, people are aiming for a piece of paper, so unfortunately, or fortunately, but anyway, because they do need that piece of paper and they get it at the end. But the fact remains that the focus once again shifts towards examination. And I agree that there needs to be that post-fellowship training, which really qualify people to become consultants. And that's something that needs to be deliberated even within the Pakistan Medical Commission and with the regulators as well. When do we actually license people for what? And if I may actually, if we look at the way we are dealing with the renewals this year time of your PMC licenses, so they're just moving from revalidation, renewal to revalidation, so that we can move towards accreditation. We're trying, but see, nothing comes for free. At least we have started a dialogue, which means there is sensitivity. This needs to continue, and I hope Dr. Saad carries on with this initiative with a series of webinars that can be used to actually promote this dialogue. And you tell us what we need to do. Professor Ashraf will be happy. I'm there to take whatever your messages are to the regulators and see how we can deal with that at that level as well. So thank you very much for a very, very useful.
So thank you. This was a very interesting session, and I really enjoyed listening to views of all our panelists. I thank you all for taking the valuable time out of your busy days. I know it's a Sunday. Thank you very much, and don't go away. We've got another anesthesia session that's going to take place in just about 10-15 minutes. So it's thank you from my side, and goodbye.
Thank you, Dr. Saad.
Thank you. Thank you. Bye then.
Saad, thank you, Dr. Saad, and rest of all my colleagues. Thank you.